Introduction. Beta blockers antagonize beta-adrenergic receptors and are used mainly in the treatment of hypertension, heart failure, tachycardia rhythmias, and angina pectoris. In addition to cardiovascular disorders, beta blockers are also used in the management of anxiety, migraine, headache, glaucoma, tremor, hypothyroidism, and various other disorders. Propranolol is one of the earliest beta blockers manufactured and has been in the United States since 1973. The development of beta blockers has revolutionized the management of cardiovascular disorders and is known to provide morbidity and mortality benefits to patients with ischemic heart diseases. Beta blockers prevent remodeling of the heart after an ischemic event by reducing the effects of catecholamines on cardiac tissue. Etiology. The etiology of beta blocker overdose is closely related to the epidemiology of depression and the presence of coexisting medical conditions that are treated with beta blockers. In one study, patients who overdosed on beta blockers were more likely to be women, 3-1, with a mean age of 30 years. 2/3 of these patients overdosed on someone else's medication or were using beta blockers for non-cardiac indications, e.g., migraine, tremor, thyrotoxicosis. Types of toxicity. Beta-1 blockade. Impaired cardiac contractility. Bradycardia, AV block. Non-selective beta blockade. Cardiac effects as above, but also bronchospasm, hypoglycemia, impaired glycogenolysis and gluconeogenesis. Epidemiology. In 2015, according to the American Association of Poison Control Center, AAPCC, database, 10,577 single exposure cases of beta blockers were reported, 9.6%, 1022, cases of which were coded to have moderate to the major outcome. 82%, 8,706, of these exposures were unintentional. The trend of beta blocker exposure from the National Poison Data System, NPDS, database reveals 118 more exposures in 2015 compared to 2014 but fewer, 8 versus 14, fatal cases. Of all the beta blockers, propranolol accounts for the majority of cases of beta blocker toxicity. Drug specific toxicity. Propranolol, non-selective, may behave like TCA with QRS prolongation. Lipid soluble, which enhances brain penetration and, therefore, potentially epileptogenic and/or leads to comatose state. Metoprolol, B1 selective, mostly cardiac effects. Higher doses, and GT, 100 mg, may also have B2 antagonistic effects. Pindolol, partial agonist, may cause sympathomimetic effects, such as tachycardia and hypertension. Sotalol, beta blocker with class 3 antiarrhythmic effects that increase refractory period by blocking delayed potassium channels in the heart, can lead to QT prolongation. Torsades de pointes, VVT. Pathophysiology. Traditionally, beta blockers are classified as selective and non-selective depending on the receptor specificity. Specificity is, however, lost in cases involving overdose. To better understand the toxicity, beta blockers are classified as lipophilic or lipophobic. Highly lipophilic beta blockers can easily cross their blood-brain barrier and may cause various central nervous system (CNS) manifestations. While CNS manifestations secondary to beta blocker overdose are primarily attributed to lipophilicity. Water-soluble beta blockers, for example, atenolol, may also cause tiredness and fatigue. The various metabolic and circulatory pathways are dependent on circulating catecholamine that, in turn, is switched off by beta blockade. While hypertension, bradycardia, decreased myocardial contractility and oxygen consumption account for the hemodynamic instability, hypoglycemia. Secondary to inhibition of glycogenolysis and gluconeogenesis may also occur. Toxicokinetics. Beta blockers are readily absorbed when ingested with peak absorption within 1 to 4 hours except for sustained release preparations. Absorption may also be delayed in cases involving the co-ingestion of drugs which can decrease gastrointestinal motility. While most of the beta blockers are moderately lipophilic, certain beta blockers have extensive lipophilicity and have a large volume of distribution. Propranolol, the most lipophilic beta blocker, can easily cross the lipid cell and blood-brain barrier and may cause seizures in overdose cases. The liver excretes beta blockers most frequently. Atenolol, cartiolol, and nadolol are the only exceptions that undergo renal excretion. Various beta blockers may cause sodium or potassium channel blockade and therefore cause prolongation in QRS and QTC interval, respectively. Sodium channel blocking beta blockers are said to possess membrane stabilizing activity, which potentiates toxicity in overdose. History and physical examination. Practitioners should take a proper history regarding co-ingestions, particularly anticholinergics and cardiotoxic medications. Co-ingestion involving calcium channel blockers, CCB, may cause profound hypertension and cardiotoxicity. Various other cardiotoxic medications, for example, tricyclic antidepressants and antipsychotics, may potentiate beta blocker toxicity. Underlying medical illnesses, especially patients with underlying cardiac diseases, are at increased risk of poor outcomes. Different beta blockers have different half-lives that may range from several minutes to several hours. Therefore, efforts should be made to determine the exact beta blocker involved. Evaluation. Exam. Bradycardia associated with hypertension may be the first clue to diagnose beta blocker overdose. In comparison to calcium channel blocker overdose, which may mimic beta blocker overdose, patients with BB toxicity have hypoglycemia and altered mental status. While symptoms secondary to beta blocker overdose usually appear early and are commonly observed within 1 to 2 hours. ECG. Look for first-degree heart block, high-degree AV block, cardiogenic shock, and other conduction disturbances may also occur. ECG usually shows normal QRS, increased PR intervals. QRS widening can occur with massive doses, and QTC prolongation leading to ventricular arrhythmias may occur with sotalol ingestion. Labs. Check fingerstick glucose, basic metabolic panel, calcium. Evaluate for possible co-ingestions, especially with other cardiac medications, calcium channel blocker, digoxin, clonidine, etc. Elevated lactate and GT3-mmol can be a sign of higher mortality, though this is non-specific. Management. Decontamination. Activated charcoal 50 grams. PO or via NG tube. Consider multiple doses of AC or whole bowel irrigation. Go lightly 1 to 2 L/H. Via NG tube, if ingested beta blocker is a sustained release preparation. Mixed data on its efficacy, however, considered low harm intervention for potential benefits. Hypertension, bradycardia, IV fluids, atropine, IV 0.5 to 1 mg IV every 5 minutes, up to 0.04 milligrams per kilogram. Although atropine alone is usually not enough for reversal in beta blocker overdose. Consider the following in this order. Glucagon, 5 to 10 milligrams IV bolus, repeat every 3 to 5 minutes if no effect. If effect seen, start 1 to 5 milligrams per hour infusion. Often causes vomiting. Consider giving ondansetron. First, note that tachyphylaxis may occur with prolonged infusion of glucagon and GT24H, and prolonged treatment will become ineffective. Calcium may assist with inotropy. Give 1 gram 10%. Calcium chloride, slow push via central venous catheter, up to total 3 grams. If no central line. 30 milliliters 10% Ca gluconate, up to total 3 grams. Vasopressors, epinephrine infusion, start 1 to 4 mcg per minute. And titrate to MAP 60. Insulin, high-dose insulin can have positive inotropic effects. Start with regular insulin 1 U per kilogram IV and infusion 0.5 to 1 U per kilogram per hour titrated upward as needed. Maintain euglycemia with D10 or D50 as needed. Be mindful of potential hypokalemia. Lipid emulsion. Infusion may be effective for some lipid-soluble drugs, e.g., propranolol, especially in conjunction with insulin therapy. Consult with poison control. EKG changes, if there is QRS widening due to high-dose beta-blocker-mediated Na channel blockade, push sodium bicarbonate 1 to 2 MEq per kilogram IV. If there is concern for QTc prolongation or ventricular arrhythmia, give magnesium sulfate 2 grams, IV and/or mg infusion. Seizures. IV benzodiazepines are first-line treatment. Bronchospasm, albuterol nebulizers. Hypoglycemia. D50 pushes for immediate reversal, then dextrose infusion for maintenance. Hemodialysis may be beneficial in severe cases for those that ingested hydrophilic compounds such as atenolol, nadolol, sotalol, and acebutolol. Lipophilic. Beta blockers such as metoprolol, propranolol will not be able to be removed via hemodialysis. Enhancing healthcare team outcomes. 1. Therapeutic uses, cardiac disorders, hyperthyroidism, migraine, glaucoma, anxiety. 2. Importance of awareness, necessary knowledge for physicians, nurses, and pharmacists. Growing cases of toxicity, though fatalities have decreased. 3. Factors influencing toxicity, timing of medical intervention and amount ingested. Lipid-soluble beta blockers tend to be more toxic due to quinidine-like effects. 4. High-risk groups, patients with heart or lung diseases, those on other cardioactive or psychotropic medications. 5. Management of suspected toxicity, immediate ICU admission. Consult a nephrologist for potential dialysis. Mental health referral for intentional overdose cases. Differential diagnosis. Antidepressant toxicity, carbamazepine toxicity, cardiac glycoside plant poisoning, cocaine toxicity, epidural hematoma in emergency medicine, hyperkalemia in emergency medicine, meningitis,